My name is Kelly Talby. I'm the Director of Policy and Strategic Partnerships here at Kentucky Voices for Health, and we are a part of the Thrive Kentucky Campaign Steering Committee. Um, Welcome to our May forum with the Cabinet for Health and Family Services leadership. We are joined today by quite a few, including Dr. Stack, Cabinet Secretary, Tricia Okeson, Deputy Secretary, Andrea Day with the Division of Childcare. We've got Tanya Dickinson in from the Department for Behavioral Health, Developmental Disabilities, Commissioner Victoria Elridge, Tom Walton, the Executive Director for the Rural Health Transformation Program. And I think we're waiting on maybe a handful others to join us as well, but we do appreciate everyone joining us today. And you can go on to the next slide. If you have not joined us before, or if you've not joined us for quite some time, this is just a reminder on some of the principles that help drive our work as a campaign. We aim to have a Kentucky where there is a welcome mat approach and all safety net access, be it for healthcare coverage, nutritious and quality food, safe and affordable housing, all of the social drivers of health that impact a Kentuckian's ability to stay and be healthy. We want those to work in harmony together, and we feel that a strong safety net is how we allow each family the ability to thrive. If you go on to the next slide, you can see the list of the steering committee members that help inform this work and organize these educational programming opportunities for you all each month. Go on to the next slide. We will have this updated soon. So I would like to give a special shout out to Humana Healthy Horizons, who has committed to supporting our work in 2026. We cannot do this without the work and support of so many donors and sponsors. We want to continue offering continuing education for these educational programmings for free. And be it the roadshow, the virtual programming, sponsorships mean the world to us. So please reach out to me. Drop my email in the chat in a few minutes, but I would love to talk to you about how to spend your money wisely. You can go on to the next slide. Here's a snapshot of the upcoming 2026 virtual and in-person opportunities. If you've not yet signed up, the links that are dark brown, maybe black, those are our virtual formats. The one that's a little more orangish red, those are our in-person roadshow stops. We will be kicking off our in-person roadshow next month in Louisville. And so if you're in or around that area and would like to join us, I hope you'll register soon. I'm going to the next slide. Just some housekeeping. There are quite a few folks in the room today. About a half year or more, we did kind of change the logistical back end just to prevent some cyber doxing and other inappropriate visitors from having any sort of influence on our time together. But we do want you to participate. So if you have a question, comment, curiosity, observation, do not hesitate to drop that in the chat, especially if it's a question, because I guarantee if you're thinking it, someone else also had that notion. And if we can, we'll try to answer those in live time so that everyone benefits from seeing and hearing the answer at the same time. If we're not able to get to it in live time, we'll try to do it in the follow-up email. Everything, including the recording, any resources or materials shared today, we will send in a follow-up email. And if you do need a continuing education certificate for participating today, you must complete the evaluation that will be included in that follow-up email. You can go to the next slide. So here's our agenda for today. And I will be handing the virtual mic to myself. We can go on into the rural health transformation section and get us started. And so Tom Walton will be joining me. Tom, where'd you go on the screen? There you are.
I'm here.
So thank you so much for joining us today. And rural health transformation is kind of the popular name among the waves these days. And so I understand you have some kind of just high level updates as to where we are. Folks can still use that website that you all have organized and its beautiful resource
Right.
repository. So I'll let you take it from here for a few minutes and let us hear what we need to know.
Sure. Thanks, Kelly. Let me sort of reiterate what Kelly just said. The Rural Health Transformation plan.ky.gov is the source of truth for our work. So again, we're aimed to have really consistent messaging. So that is the place to go. That's where our funding announcements are, our funding opportunities are being posted. So please, please go there. Uh, the other two themes that like to talk about a lot, which are extremely important to us, are locally led, state equipped. So again, we believe that the solution is to live in the communities. So please send us your ideas. You can use the Rural Health Transformation generic website. Myself and other staff look at that. So please send us your ideas. Um, the other thing is that we are traveling around the state quite a bit. So, look for, us around. We often visit local health departments. We're visiting like the University of Pikeville. We visited last week. This week, we'll be going to Whitesburg to Mountain Health Comprehensive Care. And again, the idea of all those visits is to hear the local voice to make sure that the solutions that we are proposing and funding fit the needs of the local community. Where we are in the update is the Rural Community Hubs for Chronic Care Innovation. The applications are out for the lead organizations, and just a reminder, we're looking for lead organizations in the one lead organization in each of these geographical area development districts, and they are Big Sandy, Lake Cumberland, and Purchase. Again, the idea there is that the lead organization will then convene local partners within that geographical area development district and identify solutions. Again, I can't tell you that we're going to do this, and this because we really want the initiatives to be locally led. Under the powering rural maternal and infant health, we're in the process of finalizing the contracts for those two areas. Again, one will be in Eastern Kentucky and one in far Western Kentucky. And the power teams will have, when a woman is identified as pregnant and eligible for the power team, it'll be an obstetrician, an RN, a doula, and a community health worker that will accompany the woman, and also looking at technologies to facilitate care. The rapid response to recovery is the behavioral health. We're looking at taking the principles of an empath unit that's currently operating at Eastern State Hospital run by UK, and it opening up two additional sites there. And the core idea of the empath unit is that a person who's in behavioral health crisis is not transported to a location that can't meet their needs. So again, we want to avoid transfer to an emergency department or incarceration or something like that, and really be responsive. And then also to make sure that that person is connected to follow-up care so that the whole care continuum is not interrupted, that in fact it can be accelerated because of this potential crisis. A lot of training too in response, how EMTs can respond to people in behavioral health crisis. We're looking at mobile crisis teams. Again, very active dialogue across the state for that. The Rooted in Health, we are awarding money now to public health departments to increase the number of dental hygienists, some with actually within that department, and others, there are new programs to that department. We're looking at mobile vans. One of the ideas that excites me the most is a van that goes out and actually takes an image of your mouth and then does a 3D printing of dentures on the van. And again, we think this is really responsive. We've heard from our friends in Eastern Kentucky and in Western Kentucky that when these huge tornadoes strike or the floods, that a lot of people lost their dentures and have not been able to replace them. Again, this is an example of us being responsive to the needs of the local community. Under the crisis to care, we're looking at creating a learning system so that people can become EMTs. They can enhance their EMT skills. There's an advanced EMT and also paramedicine. And again, I know I'm saying this over and over again, but it is really important to us that we bring the resources to people. And so this will be a virtual training program. And it has been floated that when a first responder is on duty but isn't actively on a call, that this would be a great place for them to get the education to increase their skill set. We're also looking at regional medical operations coordinating centers, or REMOCs. The claim to fame for these really is when, again, the floods in Eastern Kentucky, there are tornadoes in West Kentucky, it coordinates the medical response to that. but our idea is to actually make that a 24/7, 365 event so that even when any person needs a transport, they can go directly. We heard the story recently of a person who had a cardiac event and had like two transported in three different settings before he received the appropriate care. That's the sort of thing which we want to avoid by coordinating. We refer to those as our verticals, but again, they're all integrated. So again, we're thinking about, for training community health workers for the chronic care hubs, we want to make sure that they understand how to work with people in a behavioral health crisis. We want to make sure they understand how to deal with mothers and all the unique situations that might occur. And also, we continue to look at a lot of use of technology. And again, the idea is to coordinate care as much as possible from wherever the person presents. So we're taking really a no wrong door entry approach. And Kelly, I think I might have hit my 5 minutes, maybe 2 or 3 minutes ago, but
No,
it's
I
a
was just
lot
going
of
to
exciting work. So
Yeah, no, I was going to compliment you. I mean, anytime, be it behavioral, physical, any type of care, anytime you can de-escalate from an emergency situation and connect folks to local care opportunities, I mean, that's really where the magic is. This is never going to be an easy button type of industry that we've designed for ourselves in this country when it comes to
right.
healthcare and having your needs met. So we appreciate the work being poured into that for some more localized on-site, keeping folks in the community and de-escalating from emergency or crisis situations. I did drop a couple of links while you were chatting there to the Rural Health Transformation page, as well as the form to get involved locally for folks who may not have signed up. If any of what Tom just shared sounds interesting to you and you want to learn more, get involved, that is how you can kind of voice that interest of yours and reach out to the cabinet so they can get you connected to the right teams. So with that, I'm going to now pass, and thank you, Tom, again. For anyone who has any questions, please drop them in the chat for Tom. I'm going to hand the virtual mic over to my colleague, Dustin Pugel at KY Policy.
Hey everybody, my name is Dustin Pugel. I'm the policy director at KY Policy, and the last time we were all together in this forum, we were very much in the middle of a budgeting process that was looking pretty ugly, and unfortunately, it didn't improve a whole lot. There are some ways that it got better, but generally speaking, we're in a very similar situation as we were before. The session is over. This is the budget we have to work with. And now there's a lot of work going on between now and July 1 when that budget takes place to prepare for it. So with a lot of things happening at the federal level and then a new sort of budget reality that we're facing at the state level, we wanted to have our friends of the cabinet talk through kind of what the process is going to look like in the next several months to prepare for that. So we have Tricia Ogeson on today. She's the Deputy Secretary of the Cabinet to share a little bit of where they're coming from with this and then kind of what we can expect once the new fiscal year does start. So Tricia, thanks for joining us.
Sure, and I'm sorry Dr. Stack isn't available. He's actually doing one of those exercises to try to figure out, how we implement the budget that we were given. I believe, Dustin, if I'm not mistaken, one of the questions that we had was about grant funding, federal funding.
That too, yeah. So we know that there's been a lot of sort of confusion coming down from DC about what grants are and aren't available, and I know you all had a couple things you wanted to share about that as well.
Sure. So confusion is the right word. And every time we get some of these confusing messages, of course, the first one is this is not available, or this is, going to be cut, or you're not going to be awarded. It actually creates chaos and panic. Fortunately, we in Kentucky have not seen huge execution of those things we fear, and even with the information that we have gotten from the federal government, most of those have been walked back, or for some reason anyway, the money is still flowing from the federal government. Now, what we have not, anything that we knew was expiring, we got a lot of COVID money in the last several years, and those grants have expired. So but anything that's ongoing that we have received awards for, except for a few minor things, mostly in public health, those funds are continuing. So hopefully that will continue. But I mean, at least once a week, we are going through the exercise of what's real, what's really happening. Are we really going to experience what we've been told we'll experience? So, that being said, the budget, as you mentioned, Dustin, and I just read an article that you wrote, I believe it was in February, maybe it was quite a while ago, about the budget that we will be facing. If things didn't change, well, things didn't change. And so we're in the cabinet are looking at some really, really difficult choices, difficult decisions that we're going to have to make. And Justin, you know the budget as well as I do, probably better than I do. But we're working through all of those details right now to see what we can. Our priority will be to continue services to the best we can, to continue, to provide everything that is needed out in the state. But we do know that there's going to be some extremely hard decisions made, and it's not something that we are looking forward to. But we simply were not given the money that we needed to continue all the things we were doing.
Yeah, I
So,
know. Oh,
go ahead.
Sorry.
But I was just going to say, so between now and in June 30th, we'll be working through those. Of course, the new year starts on July 1. So we'll be working through those, and, notifying folks as we need to, and making the changes that we need to in order to manage this budget.
Yeah, I just wanted to mention to folks on the call, two areas that got hit particularly hard with this budget were, one, Medicaid, where they underfunded Medicaid by $691 million in state dollars. And as everyone here knows, that means that it's a lot, even a greater cut because of the federal match that we're not going to be able to pull down now. I've heard numbers as high as 2.8 billion over the biennium, which is a significant amount. Just in context for the state side, that's about a 10% cut to the state portion of funding for Medicaid. On the DCBS side, it's actually even worse, if that's possible. As a percent, it's about $171 million cut compared to what the governor said was needed for a continuation budget. That's about a 13% decline. And there's just no way to weather that without some really extremely difficult, and I would, from my perspective, damaging decisions that have to be made. So I think folks just need to be aware and prepared for the kinds of things that the cabinet is going to say. Tricia, do you all feel like some of that information is going to be available before July 1st? I assume there will be
Yes.
some degree of announcement about how those are going to be implemented before they actually hit.
Yeah. So as we're working through this, there are things that we know we'll need to do. There's another bucket of things that we're, looking at. So as we know and we're able to give word, we'll get the word out as soon as possible.
Yeah, very good. For those of you on the call who have a bent toward advocacy, and I know a lot of you do, on Medicaid in particular, there's a couple things I want to point out. One, there was $290 million set aside that could be unlocked, if you will, if a case is made in 2027 or 2028. I definitely think there's a case to be made for that, plus more money as we sort of stare down the implementation of these cuts. That case is going to need to be made between now and next session. I'll also say that we have a very sizable budget reserve trust fund, and the General Assembly chose to deposit over $300 million in that trust fund, aside from that Medicaid money. So there's definitely enough to be able to cover our bills this time, but it's going to take advocacy and direct conversations with our decision makers from the folks here on the call. So that's something I get to say as a C3 and not someone who works within the cabinet. But I do want to make sure that folks are aware of that. Great. Well, we're going to shift focus a little bit and start talking with Andrea Day, who heads the Division of Childcare. There was actually quite a bit of policy change this session with childcare. So we invited Andrea on to share a little bit about how that's going to flesh out as we move toward implementing HB 6 in particular.
Well, thank you so much, Dustin, for inviting me. House Bill 6 has been called a child care omnibus bill, and it focuses on a number of things, including reevaluating how we think about quality or our All Stars program, expanding the Child Care Advisory Council, establishing a certified child care community designation program, creating a new provider type called a micro center, which is kind of new nationwide. Also streamlining the data that's across the early childhood education sector. And then also reimagining the Employee Child Care Assistance Partnership Program. Those were some of the bigger takeaways from that bill. I'm happy to say that a lot of that work we've been talking about it, doing a little prep work as we go. The bill gives us adequate time frame. We have to have a plan together by October of this year for how we're going to set about doing the work in relation to All Stars. And then we have until 27 to get the regs changed, to get some reports going, and to make sure that all these pieces are falling into place. I think it was a very robust bill. It definitely brings the workforce participation and economic development factor to childcare that had been missing for so long. So it's really exciting. It may seem a little bit overwhelming because there's so much, but it's exciting that we get to where we need to go. We've slowly been making that progress, and this just supports us in doing that. I want to also call out that the Commonwealth has also recently announced 2 other initiatives that support childcare or early childhood education, and that is the Team Kentucky Early Learning Center will be opening in September of 26, and that program will be operated by the Community Action Council and will be available to executive branch employees. And then also Governor Beshear recently announced the Team Kentucky Pre-K pilot. Robertson and Rockcastle County are standing ready to be the innovators, if you will, to look at what full day pre-K for all would look like. So we're really excited about that and expanding access to high quality care for all of our littlest learners.
Yeah, thank you. That's a lot for everybody. I know Andrea will be around to answer some questions, but HB 6 was definitely a very thorough, large bill with a lot of components. But I do just want to point out, I love the employer-based childcare for state employees in Frankfurt that's happening. I think that's a great idea, and it's a really good way of leading the way for other types of employers throughout the state that I hope gets replicated. So it's really excited to hear that that's starting up soon. Well, that's great. I appreciate it. I think I am out of time, so I'm going to hand it over to Priscilla to kind of dive in to some pretty substantial Medicaid changes that we're going to talk about now.
Thanks, Dustin. Well, and thanks for that tee up, because there are a lot of changes that are coming to Medicaid and Marketplace over the next year, even less than that in the next like 6-7 months, where there are some substantial changes that are coming. And I'm very excited to have Deputy Commissioner Veronica Judy Cecil here to talk with us about some of the Medicaid changes, as well as David Very, who is also with DMS as the Assistant Director, to talk through some of the system updates and marketplace changes as well. So I will turn the floor over a little bit. We've talked a lot about One Big Beautiful Bill Act, or HR1, and HB2 from this legislative session that are leading to a lot of changes. Can you kind of give us the heads up, sort of walk through what are the changes that we're expecting this year? What's in the works? What are we preparing? All of that jazz.
Absolutely. Would love to do that. And if I can share, I do have some slides, or I don't have to share slides, but I know sometimes the visual is better for folks. So let's see, it looks like I can. So let me put this up. You all see that okay?
Yes.
Great. Lots of changes, as you mentioned, Priscilla, and that is not totally unusual for Medicaid, but I think this amount of change in such a short period of time is going to be challenging for folks. And there are 4 particular things, and I know we don't have a lot of time, but just to very briefly touch on, one is, I think, what most people are hearing about, which is community engagement. We're kind of calling it work and community engagement so that folks understand that there's a work component to it. They're sometimes confusing about what does community engagement mean, and we're going to do our best to try to educate folks about what is that and how do I comply with that and what does that mean and what complies with it, and and all those questions that are going to come with it. But it is basically limited to the expansion population. And by expansion population, we mean those individuals that are enrolled in Medicaid only based on their income. So they're not enrolled based on some other something else that might make them qualified for Medicaid. This is just those folks that are enrolled because of their income. And it is only for folks aged 19 to 64. They're also, even if they are expansion and they're between that age range, they could still maybe be exempt from the requirements. And so we're also going to be really trying to help folks understand, well, wait a minute, I have a medical condition that I can't work. So do I have to comply with this? And so we're going to let them understand, well, you actually could be exempt from it. Another good example is pregnant women. So pregnant women are in the expansion populations, but they're not subject to it because the law specifically exempts them. So over the next months, we're going to really try to be helping folks understand their particular situation and what might exempt them from having to comply. And what is it that you have to comply with? Well, it's 80 hours in a month that is subject to demonstrating that you're complying, that you're meeting that requirement. It's 1 month prior to somebody enrolling for the first time in Medicaid. And then for those that are currently enrolled, you have to demonstrate 3 months within that renewal period. So between renewals, you'll have to demonstrate 3 months of which, and it could be any of those 3 months that you meet that 80 hours a month. You can also meet it by just having an income of $580 in the month. So you could do all these activities like work, community service. You could be in school. That qualifies as an activity if you're in school half-time. So there are various ways to meet that or potentially be exempt from it. So we're going to be really focusing on folks. This starts January 1, 2027 for those coming into Medicaid brand new. So if you apply on or after January 1st, you'll have to meet the requirement, which means if you're applying on January 1, you have to demonstrate that you met that 80 hours in December. And if you can't, then we can't enroll you. Or if you're not exempt, then we cannot enroll you. We cannot enroll you until you demonstrate it, and then we'll enroll you in the next month. For current members, it's going to start with February renewals. So those with a February 2027 renewal will be the first current members that have to comply with the requirement. So just making sure folks understand that if you're in a January renewal, you don't have to. If you're in a February renewal, you will. So that's around community engagement. The next one is eligibility renewals are changing for the expansion population too. So right now it's every 12 months, but it's moving to every 6 months that an expansion member will have to be renewed. So let's just think about that in context of the having to demonstrate 3 months during your renewal period. So that means 3 out of the 6 months of your renewal period, you're going to have to demonstrate or be exempt from community engagement. So that just creates a whole nother level of, I think, difficulty and challenges for members that are going to be navigating that. The other thing I wanted to point out was retroactive coverage. and I'm sorry, let me go back to renewals. So that again starts January 1st, 2027. So new applicants on or after January 1, 2027 will be given a 6-month renewal period. If you're currently enrolled in Medicaid after January 1, 2027, it won't be until your original renewal date. So let's say your regular renewal is in September every year. So not until September 2027 will you start a 6-month renewal period. So everyone, they won't start that new 6-month renewal period until their regular 2027 renewal starts. Retroactive coverage. So right now we can go back 3 months. We will only be permitted to go back 1 month for the expansion population and 2 months for other folks. This can be also very challenging, as sometimes we like to go back if we see somebody's eligible and has medical bills that we could potentially cover. So that could cause some issues for some folks. And as part of to add then again on top of community engagement with a retroactive coverage, the person has to demonstrate or be exempt in that month prior to the month you're trying to go retro back to. So that can be confusing to folks as well, but we'll do our best to educate folks. And then the last one I really want to focus on for just a few minutes is one that's coming up sooner, and that's October 1st, 2026. There is a change in who non-citizens who qualify for full Medicaid coverage. Starting October 1, certain non-citizen individuals that we've been able to cover will no longer be coverable. A couple examples of those are refugees, asylees, parolees, survivors of domestic violence or human trafficking with a pending status, Canadian American Indians, those here on a conditional entry, and Amerasians are some examples of those who would no longer qualify for Medicaid for full coverage. After October 1, those individuals will still have access to emergency Medicaid. So please make sure folks understand that. If they have a life-threatening medical condition, they could still be covered by emergency Medicaid. What we're doing to implement this is starting in July. So we've been trying to take the guidance that have been given to us from the Centers for Medicare and Medicaid Services. And in July, we will start notifying those that we can identify that might fit into one of these categories that are going away for full coverage. So they will have an opportunity to let us know, perhaps they have changed their status and they're in a new status that does qualify, and we just haven't been made aware of that. But we will try to determine them eligible under other ways. But if they cannot demonstrate it, their coverage will terminate effective October 1, and they will no longer have full Medicaid coverage. They will have to utilize emergency Medicaid. So I'll pause a moment because that's a lot of information.
It sure is.
See if we have some questions.
Yeah, so I have just 2 questions to start with. One, and to Dustin's point in the chat, do you have estimates for the number of folks who will be impacted by the non-citizen eligibility, that change in October, and then the folks who might be subject to work reporting and that work reporting requirements in that expansion category?
Sure. So we're trying to refresh data very frequently. In our most recent refresh, we're seeing probably about 23,000 for the non-immigrant that potentially might have to give us information. And this is fairly new. So David, if I'm really messing this up, let me know.
I just got 24,000 in the chat, ma'am. So I
okay,
rounded
thank you.
up, but
Okay,
it's an approximation. based on who we know are refugees right now, who we know are asylees right now. And
Yeah.
they could have changed their status.
Their status.
So there is hope. But
and we are go ahead,
it's a
David.
large number.
Yeah. We will go out and try to do a re-verification. So please know that we will look at data sources and try to see if we can find the information. But if we can't, they're going to get a request, and if they don't respond, then by the date, they will have to terminate coverage.
That is so helpful. And so 24,000 for non-citizen eligibility. Do you know the number for folks who might be under the expansion category?
Again, changing regularly. We have about 400,000 individuals in the expansion population. When we try to go through and apply information we already know about them, maybe their medical condition, maybe they're pregnant, maybe they have income that meets the requirement. We are still looking in the 70,000 to 100,000 range of folks that might have to take steps to let us know something. Maybe they do have an exemption that qualifies. For example, they're 100% disabled veteran, and we just don't have that in our system yet. Or maybe they're completing the activities, but we just don't see it. Maybe they're in school part-time, and we just don't have that information available to us.
It's really helpful. Thank you. I think one of the other questions that comes up a lot with partners so far is, how would folks go about getting exemptions? I know we're still waiting for federal guidance and to sort of finalize that process, but any information that you can share just to help with that education piece now that there are exemptions that will be available, how would folks start?
Yeah,
where would they start?
Absolutely. And I could go actually back if you want, if it's more about what are the exemptions, I do have a slide on that. Or if it's just about the process, we will go and try to find whether or not somebody has an exemption. So they kind of, maybe they're in SNAP, and if they're in SNAP and they're not exempt to work requirements, so they're meeting their SNAP work requirement, then they don't have to do a thing. They are exempt from having to demonstrate Medicaid community engagement separately, and they're good to go. If they're enrolled or entitled to Medicare Part A or B, they don't have to, complete or meet the requirements. So there are a lot. What we're doing to try to help folks navigate that, first of all, we're going to have a lot of communications. So we're developing one-pagers around specific exemptions to try to help folks understand whether or not that might be them. And then if they do think that they meet one, we are, for example, you hear about the medical condition, like have a serious or complex medical condition. We're going to have a form that will allow, a very simple form that will allow a healthcare provider to just check a box to let us know they meet a medical condition that's on a list that we're going to post and have publicly available for folks so they understand both all the medical conditions that would qualify, and then the healthcare professional just check the box and say, I'm verifying this person meets it, signs it, and then they can upload that to their case so that we have that on file. And then for the qualifying activities, we're also going to have a form for them, a really simple form to say, I did work for this community organization, and the community organization representative can sign it, and that's something that they can submit to demonstrate that they're meeting those requirements.
That is really helpful. Both answers are really appreciated, because I think in general there's just so much confusion, so much changing and to keep track of anyway. And I'm just repeating that there are going to be exemptions, folks. There are opportunities to get out of not get out of it, but to be exempt from that requirement. And then a little just that it's helpful to have that heads up about what that is going to look like, how to do it.
Absolutely. And we're working on launching our website. So we're gonna get kind of like a high level, again, start that sort of education, let people understand what these words mean, what the requirements are, and we'll have the website up, and then we'll start posting. We'll post a template of what the outreach notice looks like. That's going to go to those in the expansion populations in July who have to who fall under expansion. And by the way, we have to send that to somebody, even if we can tell today that they would likely be exempt, we still have to send it to them. So a lot of people who aren't going to have to do anything are going to get a notice letting them know about the requirements. But we're gonna, like I said, we'll start to post those one-pagers and flyers just to help folks understand what it is and how to navigate it.
Amazing. Oh, for the folks who you can tell they're not going to have to do anything, is their notice going to be any different, or like from the information we currently have, we think that you may not, or is it just going to be a standard notice to everybody?
Yeah, CMS has been pretty clear about what that notice looks like. And so in it, it's just ticking off the things that CMS says has to be in there. We can't tell somebody that they are potentially exempt to that notice. We have to convey to them just what the requirements are.
That's super helpful. So for folks on this call, as their clients, as folks in their community are getting those notices, tell them not to panic. It's not starting now. It's just information, and that there will still be opportunities to apply for exemptions and to go through that process when it does start.
Yeah, absolutely.
Amazing. Awesome. Thank you so much. Anything else that you think is really important for this audience to know, things to look for, things to expect, at least until our next cabinet forum?
I don't think so. I think we've done a good job of covering it all.
Yes, you have. I appreciate this. And yes, and we always share out these slides. If you can share this with us, we'll make sure this goes out with folks. And as soon as question, when do you think your website will be live?
I'm hoping in the next couple of weeks.
Cool. Okay. All right. We will look for it, and we will share it out so that folks have that resource, a very important resource as well. And I just want to elevate Bev Beckman's comment in the chat that one-pagers are super appreciated. So love to hear that you all are developing this as well. All right. Well, just for the last couple of minutes, let's pivot to David to hear some quick marketplace and connect updates. I know enrollment since open enrollment has kind of changed a little bit. There have been an influx of exceptional special enrollment periods, things like that. Can you give us a little bit of an update?
Yeah, well, I have some moderately good news. We seem to be holding at about 81,000 enrollment. There's a lot of buzz around the national conversation and other about, well, how many of us are effectuated? Are lots of people, are they able to pay their bills and that kind of stuff? We have about 94% of our enrollees at any time who have an effectuated plan, which is the same year after year. So we're not seeing a huge difference in people making that final step. For private insurance, you have to make that first payment, and you have to also keep making that payment for the plan to actually go into effect. Not like Medicaid, where it's automatic. So, of the 80,000 that are enrolled today, almost 78,000 are re-effectuated. And to be honest, folks, there's always a little bit of flow back and forth between us and the issuers. It's rather complicated on the back end to make sure that the numbers that we're seeing are the numbers that they're seeing as well. So that's the moderately good news. The not so moderately bad news. We've had 20,000 people who have been disenrolled because they have been terminated for not paying their premiums. To put that in perspective, last year at this time we had 10,000. So it has doubled since last year and from previous years. That's bad news, because that's exactly what it sounds like it is. It's people who are making the choice or no longer can make those payments because the amount that most people owed has gone up under $100, around $70 a month, which is a lot when I'm a regular human being as well. But it didn't quadruple or anything for most people. We think that people are making the choice that they don't see it as being valuable. They see the deductibles and that kind of stuff being so high, or at least they're imagining so high. It's not going to do anything anyway. So why do I should I keep making that payment? That is not something that we want people to be thinking, because if you get terminated for non-payment, you cannot re-enroll until the end of the year for January 1st coverage. So that is unfortunate. If you look at a $20,000 enrollee disenrollment since the beginning of the year, we started out at 89 and we're hovering at about 81. You can do the simple arithmetic. That means that people are still enrolling by special enrollment. They're having kids. They're losing Medicaid and using this as a bridge to between jobs, that kind of thing. So it's still, that is a healthy sign as well. I said that all in one breath, Priscilla. I'm sorry, so I will pause.
No, I appreciate how succinct you always are, and breath control is amazing. Other thing that I wanted to flag for this audience particularly was that change about PE, transitioning from MCOs to being fee for service, because we've gotten a couple of questions about that.
Yes. Oh, hey, I think I'm going to get some backup. Yes, ma'am.
Sure. Yes, we did. So for a long time, presumptive eligibility individuals were in fee for service. And during COVID, we did move them over to managed care. And that was not intentionally going to be a permanent change. We did it through that period of time to give folks the extra case management for the COVID treatment. Now that we've moved out of the public health emergency, we have moved PE back to fee for service. If somebody, we did that May 1st, if somebody became PE eligible in April, which means and was assigned to managed care, which means they have coverage in May as well, because it's the month of application and the month after. They maintain their managed care. They keep the same managed care they were with. We did not move them from MCO to PE. It's just new people starting May 1st that are presumptively eligible or will be under fee for service. And then if they are file an application and determined eligible for full Medicaid, then they will choose a managed care organization.
I definitely wanted to flag that change for this group because the questions come up a bit. Thank you for explaining that.
Thanks for bringing it up.
And the immigration change that's affecting Medicaid will affect the marketplace on January 1.
Thank you, David.
Different there. And anticipating that, obviously the numbers on the marketplace are in the thousands, not the tens of thousands, because the numbers are smaller. We're doing what we did last year there for the folks that were under 100% FPL who were immigrants and facing issues. We're removing them from the passive renewal stream so that we don't inadvertently enroll them into a full price plan. And we're giving them notice on what steps they can do for verification of that stuff, but they will remain enrolled until the end of the year. So there might be a little bit of confusion when October 1 rolls around and see all the missing parts. That's the one pagers in the web page. So I just wanted to touch on that because the immigrant community is special to a lot of people on the call, including myself.
Yes, thank you so much for flagging that as well. When can folks in the marketplace who are going to be losing their eligibility, when would they receive that notice? October?
Yeah.
Okay, perfect. All right. Well,
it might be September.
Maybe September.
Okay. Around the time that everyone else is receiving you are enrolled in this plan this year, you are now enrolled in that plan next year. You just won't receive that, but you see something else explaining what to do.
Gotcha. Perfect. All right. Well, with that, I think we're a little over time, but
Oh,
I'll
sorry.
wrap it up. No, no, no. You all did fantastic. Thank you so much for answering all these questions and walking through this with us. I'm sure we'll have many more questions as the months continue to get a little closer to implementation. So with that, thank you both so much, and I will turn it over to you,
And for
Jessica.
the record, I'm the Assistant Director of Health Plan Oversight, one of the many divisions within Medicaid, not Medicaid itself.
Yes, sorry about that, David. Thank you for clarifying. All right, I'll turn that over to Jessica Klein now.
Thank you, Priscilla. Hi, I'm Jessica Klein. I'm a Senior Policy Associate with Kentucky Center for Economic Policy. I'm here today to talk about food assistance. So we're going to touch on both SNAP and the Senior Meals Program today. And first, I wanted to provide a little bit of background on kind of what we're touching on. So starting with SNAP, the Supplemental Nutrition Assistance Program. What we've seen recently is a kind of national trend in a reduction in SNAP participation, kind of as expected, with the implementation of HR1. And you might remember some of the things that that bill did to the SNAP program was one, it made key funding changes to pushing costs on to states for the program. It made several changes to benefit adjustments and limits, changes on eligibility for immigrants, and then most recently implemented was the expansion of work reporting requirements. So we're going to spend a little bit of time today talking about those work reporting requirements and what people can kind of expect and what they can do if they qualify for any exemptions for those work reporting requirements. So Amy Smith, thank you for joining us today. Could you introduce yourself and then tell us a little bit about SNAP work reporting?
Sure. Thanks, Jessica. Hello, everyone. My name is Amy Smith. I am an executive advisor in the DCBS Commissioner's Office. Normally, probably on these calls, you're used to hearing from Roger McCann, but I am substituting in his place today. Um, so Jessica, you're completely right. We are seeing a downward trend in our participation, and that has been since the implementation of HR1. So we're seeing roughly about a 6% decrease in our participation. And of course, that is because we have hit that mark of individuals hitting their 3 bad months, and that started in March. And so that just based on our preliminary data is showing the reason for that partial decline. And then again, we do have the reduction in our individuals who are exempt. So we also do have now. Previously, we had an ABOD waiver that waived 117 out of 120 counties, and that expired in November of 2025. We were able to re-exempt 5 of those 120 counties, which is Estill, Lewis, Magoffin, Martin, and Wolf, which means that they basically have 10%, generally have 10% unemployment rate. And consistently have that. So we were able to at least get those 5 counties exempt. So those reductions, we had the reduction in exemptions from our transition-aged youth, from our veterans, and from our homeless. And as again, you mentioned the immigration changes as well. So we are seeing that those reductions happen in our SNAP participation. Did you have any other questions for me, Jessica, on that in particular?
Yeah, so we mentioned November was the starting date for that, which means people who have missed the 3 months in the 36-month timeline, which is the time limit for this work reporting. Again, they would have seen that kind of around March and April. But can you talk a little bit about what kind of communication should people expect around this if they're one of these people that should be doing work reporting, or if they do qualify for an exemption, how would they go about doing that?
Well, we do send out communications, and those counties that are automatically exempt, they are just exempt in the system. But now we do communicate with individuals so that they understand their status, and that they also can understand their exemptions as well. So we notify them by mail, but of course they can always reach out to us. They can come in person. They can always call us. They can reach out on the self-service portal. But we also have the SNAP Employment and Training Program. So I wanted to highlight that as well as an option for a way to meet your work requirement. We did have House Bill 781 that was passed, and that really reinforced our SNAP ENT program. So that actually just mimics our federal law for the most part. It just reiterates that, but we are actually taking it a step further. We're really trying to really push that program, and we're really excited about where it's going. There is an additional reporting requirement that we are completing and we will be fulfilling, but we are seeing an increase in our SNAP ENT participation, or that's what we call it, for employment and training. We did receive a grant from Food and Nutrition Services and from a company called Leonard Resource Group. And we're really excited that there is going to be a More Than a Job campaign that's coming out. And so we've partnered with them. And that is actually, Leonard Resource Group was so impressed with our team that they are actually paying for the printing materials for that. So as we talk about budget, right, that's really great when they are so impressed with us that they're going to help us out. So we're really excited with that. And that is actually going to be regionally targeted. So when you talk about reaching out and communication, we're going to have a marketing campaign, and that'll be going out into all the regional offices to talk about that employment and training opportunity. And again, we are working on expanding into those areas as Eastern and Western Kentucky and offering more supports and services that way so that individuals can learn more about what we can offer to help them meet their work requirement.
Great. Thank you so much for those extra resources around SNAP ENT. I did get a question in the chat around homelessness exemptions. You could explain if there's an exemption around that or how people would go about that.
There is no longer a homelessness exemption. So, unfortunately, one of the exemptions that was taken away was homelessness. The other was veterans and then transition aged youth. So while they were previously exempt, they are no longer exempt. And so we are working to help meet that need and to help work with that population. We understand that that is difficult, but we're working to serve our citizens. But that's a part of HR 1.
As if I can jump in there too, homelessness will not, I repeat, not be considered a frailty exemption for the Medicaid work requirements either. Sorry for the bad news. We're doing everything we can to fight against.
Thanks for that, David. Yeah.
Yeah,
So
thank you, ma'am.
yeah, I think we all understand the importance of that and are advocating. We also wanted to announce too, just real quick, wanted to announce that summer EBT, we're always excited about summer EBT, and those benefits are expected to be issued this evening, that first round, for those individuals that have direct certification. So that will be that extra assistance for summer. And so we're really excited about that.
Great. Thank you so much on that. And so good to hear that that's going out on time. I know we were waiting to hear back from USDA on our plan, and sounds like we're right on schedule. Can you tell us who qualifies for that automatic qualification for the summer EBT program?
So they have to be what they call a compulsory age. That is 5 through 18, but that doesn't mean that you can't go out and apply if you're outside those bounds of that age. So that is that direct certification. But if you have a child that is still in school past 18, you can go and apply for benefits.
Great, thank you. And I know we often hear a lot of questions and additional resources around summer EBT. Is there a certain way that people should be communicating or asking questions if they have questions around summer EBT?
We do have a website, and it's on our DCBS site, so I can drop that for you in the chat in just a moment. So you can go there as well. And then we always will have marketing materials that'll be going out. We'll have social media presence. So you can always check those out, and you can always reach out and call our office at any time.
Great. Thank you so much, Amy. Appreciate you.
You're welcome. My pleasure.
Well, now I would like to turn to Commissioner Elridge to talk about senior meals. I know we've had some difficult conversations today around the state budget, and I know there's more coming our way. But I was wondering if you could talk to us about that and the situation with senior meals and what people can expect this summer.
Sure. Thank you so much, Jessica, and thank you to everyone for being on here. We all understand how valuable the everyone's time is, and just to be here with us today. So, the General Assembly, when they passed the budget, they reduced the state portion of senior meals or senior nutrition by 9.1 million. What that means overall for including federal and state funds to support meals through our senior centers, through home delivered meals, and so forth, is that funding has been cut by a third, or 9.1 million. So we're reviewing that information, working with the Secretary's office, who in turn is working with the Governor's office to determine what that impact will be. So more to come on that. And just wanted to share with everyone, in case you weren't aware, just how valuable senior nutrition is. We talk a lot about it's much more than a meal. If you've ever gone into one of our 194 senior centers all across the Commonwealth, there is one in every single county. It is much more than a meal. There is pickleball going on. Our senior center in Owensboro is also an art studio that's open to the community, or an art museum. We just cut ribbon on a new senior center in Rowan County. So a meal, yes, it's great, but there's also health and wellness classes going on there. There's legal assistance, just the ability to engage and socialize together. So it's much more than a meal, but we all understand the value of senior nutrition. And with the legislature passing the Food is Medicine initiative, which we're grateful for, however, reducing senior nutrition by 9.1 million has left our department's head scratching a little bit. We know that research shows that nutritious food for older adults can improve health outcomes, reduce emergency room visits, hospital admissions, and support better medication adherence. We talk a lot at the Department for Aging and Independent Living. A lot of the programs that we offer are Medicaid prevention programs, and supporting individuals who are healthy enough and income is above the Medicaid limits, but still need a little bit of assistance. We are here for them. So we will look to see what will happen with implementing a program. Previously, we supported close to around 30,000 older Kentuckians who relied on nutrition assistance through their senior centers. And have provided more than 3 million meals last state fiscal year. So more to come on that. But just a plug, if you have not been to one of our phenomenal senior citizen centers, please stop by. Again, there's one in every county. And we are ready and willing to support our seniors. They laid the foundation for our Commonwealth, and we owe it to them to make sure that we take care of them. So thank you, Jessica.
Thank you, Commissioner Elridge. One last question for you. So people should stay in communications with their area development agency and senior center for further communication about their programs.
Correct. We will be sending out information as soon as we can, once we finalize the numbers and look at the impact. So absolutely. Thank you.
Thank you so much. And with that, I believe I will turn it over to Dr. Sheila Schuster.
Muted here. Thank you very much, Jessica, and hello, everyone. Sheila Schuster, I'm the Executive Director of Advocacy Action Network, which is an umbrella organization for the Kentucky Mental Health Coalition and the 874K Disabilities Coalition, and a lot of advocacy around behavioral health, disabilities, access to care, and all of that kind of good stuff. We have a wide-ranging set of topics to talk about today, and I'm not sure who from the cabinet is talking about the change in the psychoeducational services under Medicaid. I can do it, and I will if there's not somebody. Psychoeducation has been a standalone Medicaid service for about 2 years, 2.5 years maybe. And one of the things that has been a part of that it has been delivered in many cases by peer support specialists who are used by both substance use treatment facilities and mental health treatment facilities. But there also has been some overuse and probably overbilling of that service. For most of us clinicians, we include it as part of our ongoing therapy with clients, and that is that we educate them about whatever their diagnosis is and whatever contributes to it. So there's been kind of a protracted concern about the certification of peer support specialists over the last couple of sessions. And Representative Moser wanted to clean that up this session, so she filed House Bill 470. And over in the Senate, the change was made to take psychoeducation out of the repertoire of Medicaid services that would be delivered under behavioral health and reimbursed by Medicaid. The language in the bill got a little bit strange because there were some sections that were under an emergency clause and some that were not. So there's been various communications, but we cleared up. It was confirmed at the Behavioral Health Technical Advisory Council meeting on Thursday that the psychoeducation service as a standalone service will no longer be in effect starting on July 15th. So on July 15th and after that, that will not be a billable service as a standalone service. Obviously, for those of us clinicians who include it as part of our regular course of therapy, it will still be included. So we were happy for that clarification that came. The next thing that we have on here are the changes coming possibly to participant directed services, which are part of the Medicaid waivers. They're called PDS. For those of you who are not aware of it, there's been an RFP that has been put out. Up to this point, PDS services were kind of overseen either by the ad districts or by the community mental health centers. And there's been some concerns about all of the paperwork that's involved. PDS is actually the person on the waiver being able to designate someone to provide their services, usually a family member, but also other people that they hire. So it involves a lot of paperwork and filings and so forth. And it's a somewhat onerous task, actually, for the agencies that have been supervising it, but a very important one because people really want someone that they know and that knows them to do what in some cases are very intimate kinds of services, including bathing and dressing and some of those things that some of our waiver participants need. But that is up for change, and I think there's been some question. I don't know the timeline of that PDS RFP, but I think sometime in the next couple of months. So we don't want people to be panicked that the PDS services are going away. This is not the intent of this change, but the change is to bring in apparently another entity that will be taking over the monitoring and implementation of it from the payroll point of view and the record keeping point of view. The other thing we have on here is MOAB, as you know, is the Medicaid Oversight and Advisory Board. It's a legislative committee that was created in the 2025 session through House Bill 695. It has 15 legislators on the committee, and it is a statutory committee. But it also has about 10 citizen members, including Commissioner Lee, Secretary Stack, the auditor, the budget director, and then a number of other folks. I serve on it by virtue of being the chair of the Medicaid Advisory Council. And Steve Shannon, who is, many of you know, in the behavioral health and disability world, is on it by virtue of having been appointed by the Speaker of the House. So there are some people that are on it by virtue of the office that they hold, and others. Two people were appointed by the Speaker and two by the President of the Senate. So one of the things that's happening under House Bill 2 is a waiver waitlist management subcommittee is being formed, and it will be run under MOAB, or the Medicaid Oversight and Advisory Board. And the reason that that's important is that there has been a lot of focus on the long waiting list in each of the 5 HCB waivers, Michelle P, HCB, SCL, and the actually 6 waivers, the 2 ABI waivers, and then the ventilator dependent waiver. And there's been a lot of concern about the long waiting list. We were very, very disappointed in what the legislature did not do, actually in the budget. 2 years ago, on the basis of having 13,000 people on those waiting lists, they designated 1,925 slots or positions, new positions on those waivers, the most that we've ever had. And we were very excited about that and really felt like we had been heard about the number of people of all ages waiting on these waivers. Those waiting list numbers have gone up from 13,000 to 17,000. And this time they gave us 405 slots. So not even a fourth of what we got 2 years ago. It was really, really disappointing. And we're not quite sure what that's all about, but it makes the management of the waiting list that much more important. So this subcommittee is going to function under MOAB, and I believe that there are openings available on that management subcommittee. We have not heard, as a member of MOAB, I've not heard anything about when that subcommittee is going to convene and so forth, but we're going to make sure that we've got people on there that are very knowledgeable. So we want to be sure that people understand what it means to be on the waiting list. We want to be sure that people have some sense of what they're really eligible for before they sit on a waiting list for years and years. We know that we have duplication of people who are on multiple waiting lists because they're just so afraid that they won't get those extra services. So we want to keep an eye on that, and we will bring that information back to you at the next Cabinet Thrive forum that we have. I would like to, I see where Tanya Dickinson is on, and we're happy about that. Tanya's with the Department of Behavioral Health, Developmental, and Intellectual Disabilities. And Tanya, you had sent some information, and that should be posted in the chat for you at this point. So you're going to tell us about my favorite waiver, because I worked on it for so long, is what we call the 1915I. It's not actually a waiver, it's a state plan amendment. And it is known as the RISE initiative or program because it serves people with severe mental illness and offers a range of services, some of which we've never had. This is a population that has never had a waiver before. So Tanya, take it away, please.
Great, thank you. It's always, can you hear me, Sheila? Okay, great. I've had some tech trouble, and hopefully the tech gods will smile on me for the next little while. I'm Tanya Dickinson. I'm with the 1959 RISE implementation team, and we have been working on this for a little over a year out of the Department for Behavioral Health, Developmental, and Intellectual Disabilities in partnership with Department for Medicaid Services. And as Sheila said, it is not a waiver. It's really close to how a waiver behaves, but there are no slots. There is no maximum number of individuals that we can serve at any given time. It's essentially Medicaid coverage. Individuals are covered directly through the Department for Medicaid Services rather than through one of the MCOs. And we are targeted. We serve individuals with serious mental illness. They may have a co-occurring disorder of substance use disorder. And then we offer 10 community-based services that range from transportation and medication management to housing issues, tenancy support, and some supervised residential, as well as supported education, supported employment, with the goal towards keeping folks from unnecessary hospitalizations or other removals from the community, but keep them in their homes, keep them in their communities where they can receive services on a consistent basis. In the chat is a link to our website, and you can go there, and there's a for providers page and a for participants page. We've been recruiting providers since last July, and we've been taking participant referrals since January 15th of this year. So far, we have 224 individuals who've been referred to us, and 144 of those have completed the screening and assessment process and been referred to case management. Once those individuals get to a 1959 RISE case manager, that case manager will help them select services that were identified during the assessment process and get them to those placements. The participants, the individuals, they all have choice in who their case manager is, as well as who their other service providers are. There's a link to our provider directory. You can see who are current providers of these services throughout the Commonwealth. We're operating currently in 5 community mental health center regions. These are not necessarily the CMHCs themselves, but they're geographic regions. We wanted to choose a way of dividing up the state into a way that folks would easily understand. Although we do have a number of community mental health centers, both already certified and in the process of completing their certification application. So there will be more to come. And we're hoping to get a new regions open here shortly. A region has to have all 10 of the available services in operation within the region to serve those participants before we open one. So if you go to our webpage, there's a map, and there's also a list for those of you who want to see it in text and also those who want to see it visually. So far, we've had 139 agencies somewhere in the certification application process. That begins with going to our Adobe Learning Management System and downloading the application. And at this point, we now have 18 certified providers. And we've had 32 packets submitted. So we've got another 14 or so that are currently in review by our staff. And as soon as we can get those folks approved for services, they'll get on to their Medicaid enrollment, and we will have them out in the community offering services to folks. We're very excited, and we're looking forward to opening up our next region and the one after that, and the one after that, till we're fully covered in the state. But that's all I've got for you today, Sheila, unless you have any questions.
That's great, Tanya. And again, just to remind people that you've got the data in the chat, we are really excited that it's going forward and appreciate the work that you've done. So I don't see any questions in the chat. So thank you very much. There was a question about the Moab waiver waitlist subcommittee and whether there will be legislators on it. I'm assuming that there will be. There's likely to be some legislators from the Moab. I wouldn't be surprised if Senator Danny Carroll served on it. He's had lots of questions and is very familiar with the waivers. And the question was, would it make sense to share waitlist stories with those? Yes, I would say so. So as soon as I, as a Moab member, get some notification about who's on it, and you all may get it also on the website or whatever, I'll be sure to get that out. But good question. Thank you. Let's look at the reentry waiver. This again is cause for celebration. And we have Angela Sparrow on. This waiver has been in the making for 5+ years and has actually gone live. So, Angela?
Angela Sparrow again with the Department for Medicaid Services. We are excited to announce that the Reentry 1115 demonstration project did officially fully launch and implement April 1st. So we are about 6 weeks into that project. Just kind of a reminder again, the reentry demonstration, it does include our state prisons and it does include our Department for Juvenile Justice youth development centers. With that, again, it is a targeted pre-release benefit package that is reimbursable again by Medicaid. So it is not the full Medicaid benefit prior to release, and it is limited to 60 days prior to release. So just again, for folks that may not be as familiar with the reentry project, we do have Department for Corrections and DJJ contracted with all of our managed care organizations. And so again, DOC and DJJ are Medicaid enrolled providers. They are providing some of those components of the pre-release services, so medication assisted treatment. They are collaborating with our managed care organizations who are providing and supporting pre-release case management services. So working and coordinating with Department for Corrections and DJJ, developing what the post-release plan looks like for the members. So again, identifying those physical health, behavioral health, and those health-related social needs for that individual, and of that individual developing that plan prior to them re-entering into the community. So we do have our managed care organizations in the state prisons, and so they are seeing in person the individual, meeting with the individual, making those contacts, developing that relationship and that rapport again to follow them post-release. So again, it's still new. We are still working through some of those, making sure, again, MCOs have done a great job. I know staffing for that, but trying to work through some of those logistics, again, in terms of volume of numbers across the state prisons, across the state, and what those managed care assignments look like. So again, the individual is again re-rolled in their managed care plan prior to release, and those full benefits are reinstated at the time of release. So just to give you a few numbers so far, since again implementation, we've had over 800 individuals within their pre-release eligibility period. What is important to remember that we've talked with our partners again and want to communicate is a large portion of those individuals are eligible for parole. So they may go in front of the parole board. They may not be granted parole, and then again, may not be released. So their expected release date might be moved out. If that does occur and they fall outside of that 60-day window, their pre-release eligibility is then indated because they're not actually leaving at that point in time. So we've had, I think, over 300 of those individuals fall outside of that eligibility period and not actually released. So we do, I think, have majority of those have been our adult population. Only about a handful of the individuals have been youth in our youth development centers, which is expected. That is a smaller number. We do have, again, over 100 case management visits have been completed by the MCOs in the first month of April. So again, really working with those facilities, trying to get those visits in and those scheduled. So overall, again, we're definitely making progress. We see already some opportunities for improvement, some changes, again, to be able to facilitate those visits and that coordination a little better and more efficient. But again, we are excited where we are, just 6 weeks post implementation. So.
We are very excited also, Angela. Thank you very much. And just very quickly, I think we have Carmen Hancock, and I see, Carmen, that you've put the waiting list numbers in the chat for us, which I appreciate. And again, those numbers look like they keep growing. Not a surprise. We're up to 18,136 unduplicated folks on the waiting list. Again, for those 6, really primarily for the 4 waivers that are taking up most of the waiting list. Is there anything you want to add to that, Carmen?
No, Dr. Schuster, just thank you for mentioning it earlier. And thank you for your perspective on the wait list and the impact, especially from the legislative angle. But yes, I dropped the wait list numbers in the chat. If there are any questions, you can reach out.
All right. Thank you very much.